So Gillian, perhaps you'd like to start.
I'm happy to start that. I'm Gillian Leng. I've got a medical background, and at NICE I'm the Deputy Chief Executive, so I'm here today wearing a corporate hat to give a wider perspective and some history of the work that we've done to get our guidance implemented across the system.
Hello, I'm Paul Chrisp. I'm the Director for the Centre for Guidelines. I trained as a pharmacist. I've been with NICE for just under 10 years, and prior to that I worked in medical publishing and medical communications.
Thank you very much.
Oh yes, I'm Kevin Harris. I'm the Director of the Interventional Procedures Programme at NICE and the Consultant Clinical Advisor to NICE. I also have a medical background, and I was until a couple of years ago a nephrologist.
What, sorry?
A nephrologist.
Yes, I thought it was.
We have something in common. Can I say that clearly we're all aware of NICE, and I remember it being set up, and it has been lauded across the world as being a very good organisation. One of the difficulties that we've encountered with patient groups, and certainly for my benefit as well, could you just explain to us with the processes and the policies that you have, the differences between guidance and guidelines, because there seems to be a bit of confusion and the two words are used interchangeably, and people aren't quite sure when you're talking about guidance what that actually means and what guidelines are. So Gillian, I don't know if you'd like to start.
I'm happy to answer that, and it's a fair point that it is a bit confusing, and just as a piece of context, we are doing a review of our products so that we can in future clarify some of that. But in a nutshell, guidance is a generic term that we use for anything that we issue with evidence-based recommendations. Guidelines is reserved for historically clinical guidelines, but they now cover public health and social care. So some of the recommendations that we've made around valproate, for instance, have come from our guidelines, and they are broad recommendations covering big topic areas. They aren't mandatory, but professionals are expected to take them into account, and there are various ways that their use is reinforced, for example, by the CQC and the GMC and medical defence unions, but they are advice. So clinical guidelines are advisory, but clinicians are expected to take them into account. Where people think of NICE and think that our guidance is mandatory, that relates to guidance from our technology appraisals programme. So where we look at new drugs, not valproate because it wasn't a new drug, but where we're looking at, say, a new cancer drug, it goes through our technology appraisal programme. The mandate there is that if we recommend it, it should be funded. And so hence there is some confusion that people think what NICE says has to be followed, but the mandate relates to that. The other bit of guidance that it's worth highlighting, because again it's somewhat different, is the interventional procedures guidance that Kevin's responsible for. It looks at safety and efficacy. It's our only programme that really looks at safety. Again, it's not mandatory, but when it was first set up, it was seen as a core standard. At the time we had core standards about safety and developmental standards, and the core standards were reinforced by the inspector at the time. I think it was the Healthcare Commission, but it might have been the one before then, and so it didn't have a funding requirement, but it was quite strongly reinforced in the system, and the Healthcare Commission supported that. But since the demise of the Healthcare Commission, it's not had quite such a lot of weight, and we've been working with partners in NHS England to reinvigorate the requirement for it to be taken really seriously, because it's looked at safety, and it's of course very relevant to the conversations around MESH as to why there wasn't more notice taken of the interventional procedures programme. So that is somewhat set aside because of its focus on safety, and there's more information I think in the submission that we put around various ways that the system's tried to follow that.
So can I get this quite clear in my mind, and I hope it would help patient groups. The guidelines are mandatory. There are other people who have to take them into account, the public health, social care, GMC and so on. Are you shaking your heads and saying they're not mandatory?
Not mandatory. No,
they're not mandatory.
No, guidelines are not mandatory.
So the guidelines are not mandatory. But you look to other people to implement them, to put them about, to communicate them, so everybody knows that they exist, and this is what you suggest should happen.
Yes.
So the guidance then, if it's technology appraisals and it requires funding and all the rest of it, that is not simply good to have, that is mandatory.
The funding of it is mandatory.
Just the funding?
Just the funding. So there's no obligation for a clinician to prescribe something that we recommended. But if they wish to, in conjunction with the patient, if they think this is the right drug, the commissioner can't then turn around and say, we're not paying for it, which of course might happen otherwise.
So if the commissioner says that they can't afford it, what happens then?
They shouldn't, because there's an obligation, a legal obligation to provide funding for it. And if that doesn't happen, there are ways that we would advise the patient and the clinician to challenge the system. Most of the drugs that come through that programme are actually funded through specialised commissioning, funded directly by NHS England. And we have close links with them, and as far as I know, the funding does follow because they budget for it.
So you don't take into account the commitment that the organisation may have in other fields, but you're not doing a sort of options appraisal, as it were. You're saying that they have got to fund this particular drug or whatever.
What we do is work closely with NHS England in relation to products coming through. So we look at the pipeline, we talk to them about where the cost pressures might be, so that it's planned for and in the budget and isn't a sudden surprise that would be a challenge for the system because they'd have to take money from something else. I would say 10 years ago we might have been more in that position, but with the relationship with NHS England, by and large the planning is in place, so there is no sudden surprise in relation to funding.
Does that mean it's serving the system rather than the patient? I mean, if the need is there, and you're saying, well, now we're having conversations with NHS England as to when we should have a look at these.
No, I don't. It's not about when we look at them. It's providing an alert to NHS England far enough in advance so they can plan for the funding. So we have a requirement to issue a recommendation on a drug within 90 days of it getting its product licence. And we stick to that, nothing to do with NHS England, but we just let NHS England know what's in our pipeline so they can plan for the funding. So they don't tell us not to do it or to slow it down, we stick with that requirement.
So it could be a cancer drug that actually takes priority over a mental health issue or something that the particular organisation wants to develop.
Well, most new drugs come through specialist commissioning, so there's a specialist pot of money to commission those specialist services. Mental health is usually commissioned at a different level.
Well, I was just thinking of other services that could be there. No, I'm going to ask somebody wanted to come in.
No, I won't actually. Because I don't think this is directly relevant to what we're here to talk about. Interesting though it is.
Ask. One of the things when you produce your guidance, okay, you're saying you talk to NHS about funding availability. One of the things we've heard is about skills shortages. When you do your guidance there, for example with non-mesh surgery, do you take into account the skill base required to deliver it?
The short answer is yes, and I know more about the clinical guidelines programme and conversations that we're having with Health Education England, but over the years, specifically within interventional procedures, Kevin, we've been very aware that we're making recommendations that might say, as for MESH, you need specific skills and training to use this new procedure. And we've had conversations with the colleges about providing that, so perhaps I can pass over to you to provide some detail.
No, I think that's exactly right. I mean, we don't modify the guidance in the context that we think there are people out there who can do it, because we're not able to judge whether that's the case. But we might, in our guidance, make a specific recommendation that says, for example, this must be done by people who are appropriately trained in this procedure. We often make comments about patient selection related to that needing to be done through a multidisciplinary team, and we might suggest what the composition of that team would be. But we look to the system to ensure that when they implement the guidance, those things are put in place, accepting, as Jill says, we can't mandate that to happen.
So you don't go into training needs and so forth. Can I go very particularly to the placement of transvaginal tapes and so forth? Mm-hmm. I was trying to think of any other area of contemporary medical practice where a trocar is inserted into the body without guidance. I mean, certainly when I started doing renal biopsies many years ago, you didn't do them with guidance, but you do now. Mm-hmm. Can you think of any other area where you place a trocar into the body blindly?
I can't off the top of my head. I think you're right. I think most procedures now would be done with some.
And so when you're placing it through the obturator membrane blindly, in retrospect, do you think proper training programs should have been thought through?
I'm not sure that I'm really in a position to answer that, because I'm not responsible for the training.
No, but you are responsible for interventional.
But we made it very clear that people who undertook this procedure should have undergone the appropriate training in order to do it. But we didn't define what that appropriate training was.
Yes, and when you wrote the letter to the BMJ in November, in response to the leading article on MESH, you talk about interventional procedures guidance aims to protect safety of patients. It's recommended it should be seen as mandatory, not just advisory. What does mandatory actually mean in those? I mean, if you mandate something, how can you, NICE, be sure that it actually happens?
Therein lies the challenge of the recommendations that we've issued over the years, because we don't have any powers to require anyone to do anything. So we've worked with other partners in the system who do have the ability to either require or encourage. And as I said at the start, when interventional procedures guidance first came out, it was phrased as a core standard, as something that was seen as an essential thing that everyone followed. But as other organisations changed, that was lost, and I personally feel there needs to be a much stronger requirement for the system to follow our interventional procedures programme, because it's about patient safety.
Do you think the system's broken?
I don't think it's all broken. I think there's some really good stuff going on, but I think in relation to adherence to that guidance, it needs to be clear.
So who are you mandating when you use the phrase being, I understand guidelines, you know, understood and appreciated NICE for 20 years, I suppose now, and I understand how useful guidelines are, and I understand my responsibilities when I was a doctor with relation to guidelines. But I do have a problem about what you regard as mandatory, because I want to know who is responsible for making sure it actually happens. And you say the system. Well, specifically, who, what, how in the system?
Well, what happened originally, which seemed to work, was that trusts were required to have a register of interventional procedures that we'd recommended, so that or not recommended, interventional procedures that we'd followed, so that they were, sorry, I've used the wrong word, interventional procedures that we'd considered, so that they knew what we'd said and they knew where they needed to put special things in place like audit or training. And the trust would oversee that through their clinical governance committee. And they were also supposed to look for clinicians who wanted to perform interventional procedures that we hadn't looked at and refer them to us for a view on safety. So there was a responsibility of the trust, and clearly within that a responsibility of the clinician, which would be to the trust, to the patient, but also to their professional body. That was in the days before revalidation, and nowadays there might be something you could put in place around appraisal and data collection. That was reinforced by the Healthcare Commission, who as part of their inspection would check around their core standards that the trust had those mechanisms in place. And they used to give us reports, and the last report I remember said something like 95% of trusts had that process in place.
And would that apply to the private sector too? Because a lot of this activity is taking place in the private sector.
I don't know whether it strictly applied, but informally from conversations I had with the private sector at the time, they were keen to be following what we'd said because they wanted to demonstrate that they were, in line with best practice as part of demonstrating the quality of the service they provided.
And doesn't the CQC fulfill the same function then?
It has a different approach to inspection. And I had a conversation about 6 weeks ago with Ted Baker, who's the Chief Inspector of Hospitals, specifically about this issue and whether there was more that they could do in the way that the Healthcare Commission had. And he didn't immediately say, yes, that's fine. He said that they might be able to consider looking at some individual pieces of interventional procedures guidance. And I understand it's because of the different approach they take to inspection at the moment. But whether they could do something more robustly, I don't know. We're not here blaming people. No, but exactly.
When we're just trying to understand that when you go through the last 20 years, you've been issuing guidance, and yet this has happened. Yeah. And one of the questions which we've asked quite a few people we've seen, no doubt we'll ask others as well, is we've met a lot of people who've been really damaged, and it's been them and the associations they've created and their representatives in Parliament that have brought it to our attention. As a doctor, I feel really bad about that.
Absolutely.
Because I'd have thought we would have found out about it earlier than we have done. And so the system has failed. And so the question is to try to understand how it's failed and what can we do to recommend a better way forward. So perhaps you could just muse about that.
Well, there is, of course, another element that could help for the future, and that's the element of routine data collection and a requirement for that, which would be really important for NICE and our review of those procedures. Kevin, again, I don't know if you want to add to that.
So I think that it is very clear that women have suffered as a result of this, and that is enormously regrettable. I think it is difficult not to conclude that people didn't follow what we had thought we were asking them to follow, and I think that operates at both of the level of how they performed the procedure and on whom they performed the procedures. But and I think the other big deficit was because we did by and large recommend data collection, audit and reporting, and it is evident that didn't happen to the standard that it should for a number of probably different and understandable reasons. But the one thing I think that would make the difference moving forward is if we had robust, rigorous, interrogatable systems for recording the outcomes, not only of devices. It's easy to think of this as devices, but actually of procedures that we do to people that are properly longitudinally linked. And our systems, with some notable exceptions, I think, in the medical profession, by and large, are not up to delivering that at the moment. And it particularly falls down, in my view, over the long-term follow-up. So we might be quite good at recording for a procedure, I don't know, 30-day mortality or something, but 5-year outcomes for a patient who's been discharged to primary care, they can be analysed, but it's enormously difficult.
When we met the president last week with the Royal College of Surgeons and the Royal College of Obstetricians and Gynecologists, we put to them the notion that there should be a digital database. I'm not talking here directly about a register, that comes secondary, but a database, so that whenever a surgeon completes an operation note or a procedure that you and I might have done with renal biopsy, that is registered on a database with all the essential bits of information that go into the operation note anyway, including if a device is put in the barcode of such device. So that then becomes an interrogatable database which is held nationally, which registries can then link to, and outcome data can be associated with whatever system is in place for picking up when things go wrong. Would you favour that sort of?
Well, absolutely. I mean, arguably, of course, there is a database of procedures through HES. I mean, we can argue about how effective.
Yeah, but the difference here is that instead of it being completed remotely and by a third party, this would be done at the time when you do the operation, because you're going to do it anyhow, and it would just be done digitally and away you go.
Well, absolutely. I mean, that would clearly be very, very helpful. I mean, the other thing from our experience in looking at procedures in general is, as I say, is this link to the longer term outcomes, which aren't always known to the secondary. So we have to be very clear about how the data flows through into primary care recording of data, where often there are some very significant outcomes for the patient, which might not necessarily bring them back into the attention of the hospital.
Well, that's why, frankly, and I go back in history because I was involved, as was Baroness Cumberledge, in the NHS number. That's what it was intended to achieve.
Yes. And it is a frustration to us when we come to review guidance that getting that meaningful data is extraordinarily difficult.
But 16 years ago, in 2003, NICE called for long-term observational data in relation to TVT. As you've just acknowledged, that and other guidelines that you've issued in relation to the use of mesh have not been put into practice. What do you do when you're concerned, or you are aware that your guidelines are not being observed?
We routinely talk to the key partners in the system at a national level particularly to remind them of what we've said, to encourage them to take note, but we don't have any powers over them.
Who does? Who's holding the ring?
I suppose the system stewards at the moment are the Department of Health and Social Care, and alongside them NHS England. But
if you were concerned, as you have been, and I think we detected frustration, if you were concerned that your guidelines were not being followed, and despite informal conversations with others in the system, they're still not being followed, do you write to the Secretary of State for Health and tell him about your concern? And if not, why not?
We haven't done that. We have started over the past 18 months publishing every other month an impact report in topic areas like cancer, mental health, setting out in public for the board what we know from the data that's available, what happened to our recommendations, highlighting what's working and where there are still gaps. And we've used those to raise awareness of where things should be happening that isn't at the moment taking place. So part of the problem is we don't have a huge resource to do more of that data analysis. It's if you like, a sideline. Our core role is the evidence, issuing the recommendations, but underpinning that, we know we need to do as much as we can to get those recommendations implemented. So we produce these impact reports. I now co-chair something that's called the National Clinical Audit Partners Group, so that through that there's a way of implementing things in the national audits linked to NICE guidance that haven't happened. But because we've been going for 20 years this year, there are a lot of things over that time that we've recommended that aren't being optimally put in place. So it's a large task for us.
In your opinion, does that compromise patient safety?
It may do, and there are obviously examples that you specifically the mesh example that we know that has done.
About those impact reports. So how many have there been in relation to mesh, in relation to sodium valproate? How many have been going back to the department and over how long?
Well, it's a relatively new activity for us, and so that's about 18 months. They haven't been focused on narrow topics, they've been focused on broad topics so that we can give an overview. It's not enough, I would argue. We don't have resource to do more detailed analysis. We are investing in data scientists, because for the future we need to be working more with the data that's being collected to track what's happened to our recommendations. But we haven't, and this isn't a plea for more money, but we haven't got the resources to do all of that. So that's why we've worked with people like the regulatory system in the past, where they're looking at data around what's happening. But because it is a gap. It's a gap around awareness of NICE, knowing what's good and where there are challenges, and then for us to have the capacity to, whether we write to the Secretary of State or we speak to Royal Colleges, there is.
I think we understand the point about needing resources to be able to do more of the analysis you've described. That's understood. But if you've got a concern that people are being put at risk because your guidelines are not being followed, presumably, as responsible people, you would want that concern to be lodged at the highest possible level. So the question is, has that happened? Specifically in the case of mesh, because that's one of the things we're looking at. Has that happened in the 16 years since you first said that there should be long-term observational data? Has NICE voiced those concerns to the Minister?
I think, again I'm looking at you, Kevin, I think the first point that we became aware of the challenges around implementing our advice on mesh was when it was raised by the patient groups that were also alerting everybody else anyway. I don't think we sat on any information and didn't do anything with it. In fact, I'm absolutely sure that we didn't.
But isn't it extraordinary that it's the patient groups that brought this to your attention? How can we in the future do better? How can we listen to these people? How can we identify what's going wrong, the suffering that Cyril talked about and all the rest of it? Can you think to the future what sort of mechanisms we ought to do to ensure that the patient voice is heard? Because these reviews come too late. And it's the forecast that we really need. Is that in your remit at all?
Just as a kind of, I suppose this is a personal view really, but I think Cyril's comments about the need to collect prospective data which is meaningful and related to outcomes that matter to patients, and having systems in place which analyse that and are capable of flagging to us at an early stage that there's a an issue would have gone a long way to helping with this problem. Because when we did update all of our guidance in 16 and 17 on procedures related to mesh, it was still amazingly difficult to find any objective data that related to how common or how rare these issues were. And there was absolutely no doubt that they happened, but to be able to quantify that and assess it in an objective way was very difficult. And in terms of how we produce our guidance, that tends to force us back to looking at the randomized, controlled, prospective, published data, which I don't think is the appropriate way forward.
But I go back to the question that you're there once the stable door is closed and the horse is bolted.
Yes.
And I'm just wondering, do you commission research? I mean, you must pick up sometimes things that you just feel are going wrong. Do you commission any research?
Well, in relation to research, we regularly issue recommendations for where research is needed, and we feed that into NIHR, the National Institute of Health Research, and they do their best to prioritise it. And some of that comes through when we look at the results. So our contribution is generating the research recommendations. We don't have the ability or the funding to commission the research. Can I just go back to your question around what could we do more to find out sooner the problems that patients might be having? We talked, didn't we, about having a more robust database or registry or whatever we call it for collecting that information, and that's obviously important. Challenges are the yellow card system that we have, healthcare professionals filling in the information, women alerting their healthcare professionals about symptoms that they might not think are important. So if we think laterally, I wonder if we need something that's more straightforward for patients to directly engage in relation to their symptoms, rather than thinking it's got to be a formal system. And I'm not a great expert on social media, but there are all sorts of new ways that you can find out what people have been worried about through analysing Google statistics, and you can highlight flu epidemics, can't you? I'm just trying to think a bit laterally about how might we find out what's bothering
Sort of
patients without it being through one of our formal systems, you know.
Could we just explore that a bit more? Because, I mean, I don't want to over-egg this, but our profession is essentially conservative, and rightly so in some ways, because you don't want to do things without properly investigating them, and so we are always a little sceptical about new things maybe, but the system itself doesn't seem to be very responsive to the patient voice. I mean, this would be an interpretation of what we've learned going around the country. So is there a need for some agency within the National Health Service, or in the healthcare generally, because private sector is involved, that is absolutely focused on listening to patients and drawing to the attention of politicians, because they are important in this, and the professions and the National Health Service, what is happening to patients out there, so they can be investigated and the patient voice can be heard. We used to have a patient safety organisation. It's now part, I think, of NHSI, but maybe it needs to be much more independent than that.
Yes, I mean, anything we do, of course, I think medical profession is probably trying to do it for the benefit of the patients. So getting their view on whether they've benefited is clearly the key outcome that we have to consider. And historically, I don't think we have been good at that. We've looked often at technical successes for things,
yes.
And there are a number of
not the proms and the prems, just the comms, the clinical outcome measures, not the patient functional experience.
Absolutely. I think Jill Jill is absolutely right. I think there are potentially new ways that we could begin to sample the patient voice in a much more timely and earlier way, and using social media. We have tried to look actually internally within IP as an internally generated research project, whether you can sample social media, not in a mesh related context, in a way that might be meaningful. Because there are people who...
Yes. When NICE was set up, and I remember well, and some of us argued for such a body that would be advisory about what the value of an intervention was. Was it safe? But also, was it affordable? What's the cost benefit? All that. And the notion was originally that it would be advisor and government, and the department would decide. But its independence was fundamentally important, as I recall, and still is, no doubt. But don't we need something that really expresses the patient interest, the public interest, independent from the service?
Can I just say that years were taken off my life when I took part in the 2012 NHS and Social Care Act, and it took a huge amount going through that particular legislation, and you know we had a pause in that and all the rest of it. But one of the things that we were determined to do in that act was to introduce Health Watch. And I just wonder if that is something that comes across your desk at all. And also, I wondered if you had any sort of relationship in a wider sense with the ONS, because they seem to produce quite a lot of very interesting information, and also research. They do research. So I appreciate your having to deal with all these different arm's length bodies that were set up through that act, and also, of course, the major NHS improvement and all those other ones. So I just wondered if you have thought about that.
There's a few angles to take, and one is in relation to our specific process around developing all the guidance. We always have patients on the committees, and sometimes we have people just coming to the committee to talk about their experience as individuals. Over the years, we've tried to get sort of more summarised perspectives of the patient view, because otherwise it relies on one or two individuals. It's not been easy to make that happen systematically, again, because it's quite resource intensive. Some charities provide it, but it's not a routine part of what we do, that sort of patient evidence that draws it together. I think it would be good if it were there, but it isn't there. That's why it's resource intensive. So we do that in relation to guidance development at a sort of cross-cutting level. We do have links with Health Watch. I don't think Health Watch has ever contributed to our guidance. They seem to be more interested in their local systems, and do advocate on our behalf to get guidance used. So our local field team talk to their local Health Watch representatives, so it's more sort of flowing out rather than data back to us. We've got some links with ONS, not extensive ones, but are building links because of our developing data and analytics work that I've mentioned. We had links years ago with something called Health Talk Online. I don't know if that's still going. It was set up in Oxford, I can't remember who set it up, as an evidence-based way of bringing patient experience to life. With a patient audience, though, it wouldn't have been aimed particularly at NICE, but they did some really good work at bringing together the patient experience. We did have a lot of input to NICE's work through our Citizens Council. I don't know if you're familiar with that, but that was less the patient voice, more the citizen voice, 30 people representing the general demography of the UK, to give us a view on the importance of key things like how much we should prioritise somebody young over somebody old. They said we shouldn't. You know, those sorts of key questions they gave us input to. So to say, is there a gap? I think that there is a gap. We do a lot of work around shared decision making and work with lots of partner organisations, and it's clear that the research around what matters to patients sometimes comes through individual trials, but often is missed. So, for instance, breast cancer, clinicians seem to grossly, let me get this right way around, overestimate how important it is for women to avoid mastectomy, whereas if you actually talk to women, they're not as bothered as the clinicians think they will be. So it's that sort of sense of what really matters to patients that we've spent quite a lot of time thinking about, probably less about getting that feedback after we've issued a recommendation, which is key to this inquiry, I know.
And just on that sort of theme, when you're drawing up your guidance, if you've got evidence coming in from sort of charitable groups, from patients, from individuals, how do you, and also obviously randomised controlled trials, POMS and programs and POMS, how do you sort of weight those different types of evidence?
It's a really good question, and I suppose the short answer is we don't have any formal weighting system, and I've got diagrams that I use for explaining how NICE works, where we put the science, if you like, the randomised controlled trials and other published research in the middle, and there are other perspectives that we then bring to it. Obviously, very importantly, the patient perspective, but it's a perspective that we've built around the evidence, and that's where our independent committees are really, really important. They include the patient as well, and they have to take a view on all of that and decide what the recommendation should be. It's not an exact science, so there's no weighting. We have thought over the years about should we actually try and make this more scientific, but it's really not straightforward.
So is there any internal coherence? I mean, the groups are coming together and weighting things differently. If one was to look at a spread of this, would we find internal coherence?
It's a fair point, because sometimes we have different committees that would look at something originally, then another committee would update it. The mitigation to that consistency check is that we have a quality assurance programme and we have external consultation with the stakeholders, and that consultation, although time consuming, is really important to do that system check. People will very quickly tell us if they think we've got it wrong.
Can I go back and ask about evidence base? Because one of the things I think you were saying was it's very difficult to know whether we've objectively got the evidence that we actually need. And I think when it comes to efficacy, it's quite clear that you look at peer-reviewed literature and you'll look at registries. It's different for safety, but that's what I understand from your evidence to us. So I suppose my question to you is in relation to MESH. If we have substantial doubts, and the patient groups have expressed this very coherently, that we're not picking up all the adverse outcome measures, and the literature is not doing that, and we don't actually have registries, because we haven't got to that place yet. Mm-hmm. So I'm sort of left asking, what is the evidence basis for deciding that MESH is efficacious?
I don't think that's really what we said, was it? I think if you look at the recommendations around MESH, we were always very cautious about its use and made it very clear that nearly, for the vast majority of the procedures, that it had to be used cautiously with the risks of potential side effects being explained and the uncertainties around the procedure being explained and the requirements to collect more data moving forward.
Well, I suppose for me it's the evidence base you're looking at, because as I say, we're now disputing that the literature actually does what it's supposed to do, i.e.
Yes.
come up with all the adverse outcomes. There aren't any registries, so I'm not now sure where you're looking to for your evidence to be able to say anything conclusive about that.
Well, we clearly, there is published literature.
I know there is.
That people have called into question. We do try and get patient feedback from people who've had the procedures, actually. That's quite a difficult thing to do, or it's difficult to get any quantity of patient feedback for that. If you look specifically at the patient feedback that we'd obtained for MESH, much of it was positive, actually. Not all of it was positive. All of that would have been put to the committee. And in terms of the internal consistency for interventional procedures, the committee is the same for at any one point in time for every procedure to look at. Clearly it changes with time as people demit and are recruited onto but it's the same committee that looks at all procedures. So the intention is they weight all the evidence in the same way.
Am I right that evidence related to safety can come from any source?
Yes.
It's not specifically from peer review or RCDs or anything.
That's correct. Yeah.
Including unpublished sources.
Yes, that's correct.
And a future vision. Paul and I were at a meeting before we came, thinking about how NICE should work for the next 20 years, if we get 20 years. And the vision has to be that we're issuing these recommendations and that the feedback loop is drawing on data that's routinely being collected, so that it's not just reliant on the published research, which might not have answered the question, but there's a link back to the data systems. Hence lots of conversations, the burgeoning analytics team, but when we actually reach that state, I'm not sure, because it's partly what we do at NICE, but also having the system geared up in a position to do that for us.
But on the point about unpublished data related to safety, I mean, obviously that could be a channel, as it were, through which patients could provide information, and that could be very helpful because it's clearly lacking at the moment. But it's also potentially a channel for someone to assert that something is safe.
Yes.
So if you go back to CERNIP days, our understanding is that CERNIP changed the categorization of MESH based on unpublished data received from the manufacturer.
Well, I can't comment on that.
Is it possible that something like that could happen today?
I mean, our understanding is that the data that was presented was conference abstracts, so it hadn't been peer reviewed and was presented by manufacturers.
So within the IP interventional procedures process,
this was back CERNIP days.
Yes, that couldn't happen in interventional procedures.
But that couldn't happen now.
No, absolutely not. And
so sorry, just to be absolutely clear, so any manufacturer of any device that you're considering as part of your decision-making processes, if they come along and say, we've got such information that demonstrates that this product is safe, not just efficacious but safe, how would you treat that approach from that manufacturer?
If it was anecdotes, effectively they were just telling us that, we would ignore it.
If it was a presentation from a conference,
we would. If the only reason we would ever look at that evidence is if they said it was unsafe, and then we would report it.
Right.
And that's true for any source related to safety. So if when we're looking at a procedure, I mean, the medical literature on most procedures, of course, does list safety and adverse outcomes. If there was something that someone told us about a safety concern that wasn't already reported in the medical literature, we would specifically comment on that in addition to what the literature had told us. Usually, it's usually done in a style of a committee comment. The committee was informed that this was also a safety concern.
Could you just tell us about this committee? Who's on it?
So it's a standing committee of NICE of 24 people, which consists of it's roughly half are doctors who do interventional procedures. There are people from the regulatory bodies such as the MHRA. There are managers from the NHS, and there are patients, there are statisticians.
How many patients?
2. Or patient representatives, actually. I don't know whether patients are not. And it's a standing committee which looks at all procedures. Their job is to look at the evidence, not to be experts on that individual procedure.
Does it have any relationship with your citizens' forum? which I remember when you set up, that was a very important part of.
The link is that the deliberations of the Citizens' Council formed value judgments, a set of value judgments that all our committees abide by, so there's some wider context for how the committees take decisions, so that's the link.
Does your committee give equal weight to patient-related outcome measures as it does to clinical outcome measures?
Well, it gives equal weight to all the evidence that it can look at. It frequently, in fact usually, would comment, because they're often missing, that what is needed is relevant patient-related outcome measures. And
when you make that decision, how do you then how do you get an answer to the question you've raised? Go to NIHR, is that how you...
Well, that might be a route, yes, certainly, but we can't send all of our topics to NIHR, but the relevant, important ones we do try and escalate to them as research priorities.
So you put out information that in a draft form, sort of guidelines or whatever, and then it's out for consultation for 3 months or something like that.
Shorter than that, yeah, but yes.
Sorry?
It's a little bit shorter than that, but yes, I think, but yes.
And so what do you do when you get tremendous response to that in perhaps a way that is not helpful to those who've been on the committee?
Well, I think the responses are always helpful to the people on the committee. Actually, I can't think of an instance where that wouldn't have been the case. After consultation has closed, all of the consultation comments are tabulated, and they're all sent to the committee, who discuss each of the consultation comments one by one and agree over a response to them.
Can I be very specific about MESH? Mm-hmm. We've been told going around the country that the outcome measure which everybody thought was important was whether or not women were continent. But the patient said to us, what about all the other things we've had to experience, the pain, the dyspareunia, those things? Nobody asked about those. So if you've got a committee that's looking at the effectiveness of intervention, and shouldn't it have more patients on it, who can actually talk about the outcomes that matter to them, not just the outcomes that might matter to me as a doctor?
The patients who are on it are certainly not there. Certainly not afraid to comment on the things that matter to them, would be my observation.
No.
We do, as part of the evidence gathering, try and get responses from people who've had the procedures, if that's at all possible. I will be the first to say that the responses to that tend to be relatively small in number, and are potentially open to bias, actually, of course.
And decent research should have picked up those adverse consequences. I mean, it's a bit worrying if it wasn't coming.
So specifically in answer to your question, MESH, those are adverse events that we described in our literature reviews of MESH, actually. They weren't new things that people told us that weren't already in the literature.
Can I just ask about sodium valproate? Are you between you confident that the pregnancy prevention plan is assisting women in making informed choices and avoiding risks, harm to their children?
Yeah. So again, the pregnancy prevention plan was an MHRA recommendation, as you know, and what we do is we reflect those signals and the information that comes from the MHRA about the restrictions placed around any medicine, and reflect that as quickly as we can in our guidance. So I guess the remit and the actions that were taken by the MHRA and the CHMP on what would be an appropriate mechanism to protect girls and women of childbearing, potential from harmful effects of valproate. That was their recommendation, which we reflected in our guidance.
And do you have continuing discussions with MHRA about the effectiveness of the PPP?
We have regular contacts, yeah. We have a regular meeting every 3 months, and we track past guidelines where there's been a safety signal, and we look forward as well for any guidelines that are on our books that may have a medicine which the MHRA can say, well, actually, we know that the Pharmacovigilance Risk Assessment Committee is looking at a medicine in this space, so we keep in close contact so that we're able to respond quickly on any signal, any safety signal, and reflect it in our guidance.
Have those discussions with MHRA, specifically the discussions about valproate, included the voicing of any concerns about the effectiveness of the PPP?
They haven't.
So as far as the MHRA are concerned, and your own position in conversations with them, you don't see any problems with the PPP?
No, we reflect on what the Pharmacovigilance Research Advisory Committee, they're charged with looking at the safety of the medicine.
Are you aware of patient group surveys about the effectiveness of the PPP?
No.
Do you think we should be?
Well, again, I think that's those safety signals. When we look at our guidance, we look at any safety signals that would have an effect on our recommendations, be that from the MHRA or published in the literature, that would make us stop and think and conduct a review of any of our extant guidance and update them as appropriate.
Your guidance effectively reflects the PPP.
We take a steer from the regulator on medicines.
Your guidance is being implemented, PPP should be being implemented fully without problems.
If our guidance is being implemented, then women and girls of childbearing age should only be offered valproate, as you know, if there's no alternative or exactly. So that's our recommendation.
Yeah. So you have no follow-up on knowing if that guidance is being implemented. Is that what you're saying?
I guess we've got soft follow-up, and by which I mean we've got a number of channels out to prescribers and clinical pharmacists. So we have a network of 80 medicines and prescribing associates who we work very closely with, and alert them as to any safety or indeed efficacy changes in any of our guidance related to medicines. They are part of their local health economy, so it's a method of getting messages out to frontline quickly on any changes to our guidance. And we haven't had any feedback from them on the pregnancy prevention program and valproate.
It's a challenge because NICE isn't charged with policing the system, if you like. You know, that's not our responsibility. And in the early days, the chairman of NICE thought that we shouldn't be doing anything after our guidance was issued. He did change his mind, and hence we started that wider engagement around how do we get traction for what we've recommended, what are the levers in the system that we can use. But our approach has been one of working with partners and looking for where there's something new that means we need to change our recommendations. So it's been historically more about when's there been new publications, and we're gradually moving into the let's see what the data says space. But it's a transition for us, and again a challenge because it's not our role to.
No, and I think we understand the silos, and that's part of the problem perhaps, that you're all in silos. There isn't a joined upness about that. There's a risk of there not being one. But in the case of the pregnancy prevention plan, it's rather like patient-reported problems in relation to mesh. But if a patient group, as they have done, have conducted a survey of women and found that women are still not being warned, women of childbearing age are not being warned about the risks of outbreak in pregnancy, and they're not being asked about PPP, then whose job is it to do something about that? What do you think in terms of whose job it should be?
We can help. We can certainly help, but you know, again, it's that collective responsibility, which I know we've mentioned before. But I think it's working with. If the MHRA are saying this is when this medicine should and shouldn't be used, and these are the mechanisms we've got in place, then perhaps the expectation would be there is some feedback loop based on that. And again, we can then react to that and get it into our guidance as quickly as possible or into the BNF. So to me, the pieces might be there, but it's joining them up in a more effective way.
And who should do the joining up?
I guess it goes back to the point we made earlier about who has oversight of all the different arm's length bodies.
I'm not at all convinced about collective responsibility, and it seems to me that it's a very good way of passing the buck to somebody else. Is it not possible, and I appreciate the position you're in, and it must be very frustrating for you from time to time, but working with these other agencies, isn't there something you can negotiate with them without breaking the law? And I'm not asking for that. But is there not an opportunity for you to ensure that one of the organisations takes the lead in this particular area, and another organisation possibly takes the lead in another area? So at least we, the citizens, have some knowledge of where the responsibility lies and who is going to do what, because at the moment we don't know.
I think that's a really important challenge for us. It's an important piece of work we need to take forward. And I'd be very keen to get involved, because I've spent years trying to get the system to work together. I guess I worry that there's not the capacity anywhere to really make that happen, because it's such a complex system. So yes is the short answer. But
it's quite an interesting exercise to write down on a piece of paper all the people and agencies and bodies that might take part in this play.
And there is, of course, the new patient safety work that's being led by Aidan Fowler. I think we talked about patient safety work. He wants to set up a committee overseeing patient safety. Whether that will have the capacity to do this, that might be a good place to oversee it. What NICE is wanting to do for the future is to bring all our advice together, because it is quite diffuse. You started off asking me what's the difference, and it is confusing. So we want to bring it together. We want to highlight some of the areas where there are safety concerns, because one way of dealing with the fact that valproate's being prescribed without the conversations happening is making sure there's always an alert. People ignore alerts, but if you've ignored an alert and something goes wrong, it should be professional misconduct, one might argue.
But it's also a learning opportunity.
Learning opportunity.
So the system, but that's not just for the individual, but for the system. So if a pharmacist or a doctor is still supplying valproate to a woman who then goes on to become pregnant because she's not been told about the importance of pregnancy prevention, it's not just about hanging them out to dry, if that's appropriate. It's as much, if not far more, about how do we learn from that and make sure it doesn't happen again.
I think that's really important. We touched on the point of being responsive to the patient voice and Health Watch. And it's funny, Health Watch volunteer.
Oh, so, right.
But there's a whole cultural change, I think, in this about. So it's related to the patient voice, and I think there's, I guess the other cultural aspect is that learning from mistakes. And we've got, and I know this is a very nice response, but we have a guideline on medicines optimization, which is all about reducing the hazards in medication prescribing. So it's about how do you get safe, effective medication, working with patients, getting their values and preferences, and ensuring that they get the right medicine at the right time that's right for them. So it's important for what matters to them, so they don't get tons of medicines that they don't particularly want or need. And it's about building a culture of learning from mistakes, and that's one of the recommendations that we came up with for that guideline. And again, there's another, driving that into the system about how you can have effective medicines optimization, including sodium valproate, but less controversial drugs, can we say, because that's how medicines should be delivered. And to do that, you need that culture. And it's working with other agencies to try to build that culture. Sorry, I get the point.
Are you confident that optimization, medicines optimization guideline is being followed?
Yeah, I think because it was also a push from our colleagues at the Royal Pharmaceutical Society as well. So there was a two-pronged approach. So the pharmacists' professional body was leading on it. We developed a guideline. It's front and centre of the way clinical pharmacists think. And it's how do we, and I think there's again another opportunity with the long-term plan of getting pharmacists into GP practices about how you can start to influence it at that point in the system. So, I think it sounds like a cop-out, but there is this. It is a cultural change. It's a change from the relationship between doctors and pharmacists. It's a change between where patients and their relationship with clinicians, and I think you can start to see that happening.
Can I ask them very direct follow-up to that? The learning experience as a result of that, has that influenced the way you approach guidance and guidelines in relation to the next generation of anti-epileptic drugs like Keppra? Has it had an impact?
Okay, so we're updating our guidance on epilepsy, and I think that's scheduled for next year. So yes, I think when we look at a guideline, scoping is the first. I'm not going to get into too much of the detail of it, but getting the scope right is really important, and that's where you can also get patient views and healthcare professional views and commissioner views. Have we got the scope right on this? Are we asking the right questions? What's your experience of the management of epilepsy as a patient and as a clinician? And from that you can start to frame the research questions in how we look for the evidence, make our recommendations, and highlight where there are evidence gaps.
So has it changed as a result of what happened with valproate? So we're looking at the new guidelines, we're just trying to work out what the practical changes were.
I guess I can't say definitively yes, but it will have. I can't give you specifics, but it will have, because valproate was such a signal sentinel medicine. So that learning and the management of epilepsy will be within the scope of our guidance.
One of the things that you said earlier was about your research recommendations going to NIHR.
Yeah.
Do you know, can you tell me what proportion of those recommendations actually get funded?
I haven't been given a recent number, but I have heard in the past, and it's not huge, it's more around about 5-10%, I would suggest.
So coming from NICE recommendations, maybe only 5-10% actually get funded.
But we do meet with NIHR. At the moment, I think it's annually, and discuss what those research recs are and help to prioritise from the research community's perspective and our perspective in terms of all of the research recommendations we found. When we go through our guidance, we can often find lots of gaps. Which ones should we be prioritising? And when we do find one, we work closely with the research community to try to get that evidence into the guidelines as quickly as possible. There was one example from last year where this may sound like a long time, but it was a year between the research being published and it appearing in the guideline. Now that's actually quite rapid. It may not sound it, but it is quite rapid in terms of the fit between the impact of the research making its way through guideline development process.
So Sarah and I just want to go back to mesh. Can I just ask this question and then pass you over to Sarah? In the current guidelines, transvaginal mesh is used only in research. That's the current guidelines. It's used only in research. But it appears to have been omitted from the draft guidelines. And we wondered why this change was made.
This is the guideline.
That's the guideline, yes.
It's the one you put out to consultation,
yes.
and its consultation is closed.
Yes.
But having previously said that as a result of the trial, you would not recommend placing mesh through the vagina, you've not put it in what you sent out to consultation, which we couldn't understand that.
So it will have been because of the evidence that the committee looked at that they felt that in that indication it should only be in.
Are you sure it's just not been left out? Because the FDA's had a whole day event on it last week.
I can't imagine it would be because it's just been left out.
That's strange, because the trial was pretty clear.
Yeah.
Will you check that,
Yeah.
please? Can we then go to mesh, back to your guidelines on mesh? You've gone out to consultation. You'll be coming in with your definitive advice sometime soon?
April.
In April. Okay. But it's very much about stress urinary incontinence. We're also wrestling with retropexy and things of that nature. And are you involved in that at all? Because we talked about the need for research. Unfortunately, they've not been able to complete the trials that are underway because there are problems with equipoise and now numbers. But there's still a very great need to get more information to guide patients and surgeons as to what's to be done. So are you involved in that?
So we have been, and I think we published guidance on mesh rectopexy. We are from time to time notified about other procedures that involve the use of mesh. I mean, most recently, for example, we looked at mesh hernia, mesh stoma reinforcement, stomal hernias. Again, the process is, from our perspective, is exactly the same.
If there was a need for more research in this area, which
yes,
I would suggest there is, and we've been talking to the people involved, the Pelvic Floor Society, the Association of Proctologists and so forth. Would you be involved in putting a proposition to NIHR about funding for that sort of work? Or?
We certainly could be. We haven't been to date. Yeah. I would need to go back and look exactly what we said about mesh rectopexy, but my recollection is that we did recommend data submission to their register, I think. But
yes. Okay.
One of my questions, your guidelines throughout for stress urinary incontinence have said that there should be submission to registers, so the voluntary registers. But those registers by their nature are voluntary, they're run by the societies, and the one thing that's very clear is that data capture isn't complete. So how can safety recommendations sort of flow from such an incomplete source?
Well, I think you've made a very good point, really. I mean, I believe that originally when those recommendations were made, they were made in good faith, believing the registers to be functional, actually. One of the things that we've clearly learned is that, and we alluded to it in our published literature, that when we've reviewed some of the registers, not just related to mesh, that we've recommended over the years, many of them haven't been functional.
Well, they don't collect patient identifiable data because they're worried about GDPR.
Yes.
But in fact, that could be dealt with, but they don't. And therefore, the notion of being able to trace up from a database things that are going wrong with long-term complications doesn't exist.
In relation to the BOWS and the B-side registers, no.
Well, to the registers that you sort of said should happen.
Not all of the so one of the things we have learned is that not all registers are equal in this regard, and there are some which I think are highly functional and produce very useful outcome data.
In the mesh area?
No, sorry, no. In general, talking absolutely not.
Bone and joints, and maybe.
Yes, and NICOR and so on. I think have been very effective. And the committee was actually minded to make a specific comment in its updated guidance on one of the procedures about how disappointing it had been about the performance of data collection through the registers. That's not helpful in a way. What we actually need to move forward to is a position where we have functional
as we've discussed.
And we would absolutely support that wholeheartedly. We recognise that there are some challenges to that, and not least resourcing appropriately. But I think everybody, certainly in the Interventional Procedures Programme and on the Interventional Procedures Advisory Committee, would value that enormously.
I mean, going forward, you're clearly people who rely on registry data, so in some ways you're possibly some of the best place to say this is what we want from a registry. So what would you say were the absolute sort of key things that you want?
So at the moment we have 4 or 5 criteria that registers have to comply with, and this is relatively recent, but we ask them to self-declare that they perform against that. I think again we are learning about what makes a good register actually, and one of the things that is clear is its ability to be appropriately resourced, and so it's very easy to say we will collect data on all devices related to this procedure, we will analyse the data, we will abide by data protection legislation and so on. The actual key is whether they're resourced adequately to do it, and I think in retrospect, when we look at the ones we recommended with MESH, it was clear they weren't resourced adequately to do it.
And one of the things that NHS England have told us in their written evidence is that registries are very expensive. And they go on to say that, and presumably they do link the 2 points, we'll ask them when we see them shortly, that it would therefore be better to have fewer of them, but each registry covering a wider range of procedures. Would you agree with them on that?
Well, I mean, I have a personal view here. I mean, it is a personal view. I think to a certain extent they're right. To have a register for every single procedure would be an astronomical cost that probably couldn't be met. To have a more smart, linked up system that uses data that we already routinely collect and that properly analyses it, I think it's a personal view, is a more achievable goal.
So if there was a gynecology register, for example, as broad as that obviously is, would that be a sensible way forward?
Well, I would, to be honest, I think there's an argument for going broader than that. Many procedures are uniquely identified through HES coding systems. If you can link the patient who has had that procedure all the way through their clinical manifestation outcome, I think that ultimately is something. I don't want to underestimate, because I'm not an expert in this, how difficult that might be in terms of legislation and technical things, but it would give you the ability to look at things that might really matter to patients, and to look at things that you might not anticipate are related to that procedure. So I'm giving a fictitious example here, but if you have a procedure that you've labelled as gynecology and an outcome measure which is actually very important to patients isn't obviously a gynecological one, just within the gynecological register that could be very easy not to identify. Whereas,
so how do you where's the boundary then? within the register? I mean, is it just a register of every single procedure that happens across medical practice? I mean, are we just having one national registry for everything? Because you're right, I think we'd agree with you that the point you just made is absolutely right.
It becomes semantics about what. So at least in my view, the traditional view of a register is that somebody's got a database somewhere and everybody submits data to that with predefined outcomes, and then somebody analyses against that. I think there is an opportunity. Well, I've always thought there was an opportunity. Again, it's a personal view that. We have got a national health service. Everybody is identified by their unique identifier, and we have a service which actually delivers rather tritely called cradle to grave medicine for most people. If we could join that up properly, we could get some meaningful data.
We've heard from the president of the Royal College of Obstetricians and Gynecology that actually if we had a proper database that affected the life course, so that when a woman had a difficult birth and later on became incontinent, then you could actually relate it and see really some of the causes and how to put it right and all the rest of it. So it seems to me that we're actually just entering a new world, and it could improve patient care hugely if we adopt it in the right way and put in the right infrastructure and the right resources, because it is going to be really, really important. And with maternity, which Cyril and I are involved in, it's very interesting that that is a cohort of women who absolutely understand the new technologies, and they will say to us, my life is on my iPhone. Where are you, NHS? You're in the dark ages. So we've got to get further forward onto the right foot and introduce all these, and I think it would improve safety and just the way that patients then are looked after, cared for, etc.
I would agree. I think that registries shouldn't be too narrow, and we should be thinking about a future where we've got good quality data routinely being collected, and some of the more techie people I speak to are thinking of a world where it's all the voice activated technology, and that will just be able to pick up the information and code it seamlessly. And that would I've got Alexa, that's about as far as my voice activation goes, but you can see the potential of that, and perhaps in the future we will be able to draw upon this.
And I think it relates to the earlier point about working with the Office for National Statistics as well, because that is, as Jill mentioned, we are doing some exploratory work with them to see if we can track a signal across different recommendations on relatable pieces of information, if you see what I mean, across our guidelines. I'm not explaining that very well. So our guidelines are discrete pieces of information, but if you can link a signal over here and track it across in a quick way that says this recommendation is related to that and is related to that, then it's similar to your life course database. You can start to draw on data and not go through a process which is prone to error, and you can start to employ technology to identify where that signal could impact on NICE guidance and other people's outputs and regulatory framework, or however it might be. It's all about how we code and capture and make the bits of information talk to each other and relate to each other, I think.
Because that's another challenge. There might be a fragmented system around implementation and patient safety, but it's also fragmented in relation to data capture and analysis.
It comes back to who holds the ring on all of this.
Yes.
And I think, I mean, are you saying it's the Department of Health who ultimately would need to make this happen?
Part of it. I mean, even that is for us, for our world in healthcare, and with the MHRA and our system partners, yes. But again, you could say, well, how does that link to the ONS? Because that's another bit of the world. That's not DH. So, you know,
it's one step at a time.
Exactly.
Yes, just a couple of questions from me. One of the bits of information that you draw on when you're looking at the guidelines, is more data, the American equivalent to our yellow card. I just wondered what your view was about that, because the patient group said to us they would like to have a MAUD system here. We've got yellow card. What's your view?
It's a personal view. I mean, I think it's better than we've got here, but probably has a number of imperfections.
And they are, I mean, just, we're looking at systems. Let's just see what else is on offer.
I mean, again, any system that relies on reporting rather than collection of data is inevitably going to be challenged and incomplete, isn't it? Because we know people don't report things.
And their view is it's much more open and transparent. You can
Yes.
certainly interrogate it, whereas you can't do that with the other card system.
Yes. Well, yes. So all of those things I think are true.
But from your perspective, sitting in NICE and having used that data, is it better data? Are you getting more than you would be from the other card system?
I think the signals are stronger, certainly, but are they complete? I don't believe they are.
Okay, so signals are stronger. That's a good one to take away. My other question is translabial scans. I know that in the guidelines, the consultation document, it's mentioned there as part of the mechanisms for investigating, citing mesh, but you don't place it in any sort of hierarchy. The patient groups tell us that's really important, that they would like to see a lot more of it. There just aren't the centres where they can get translabial scans.
That's a clinical guideline.
Yeah, is that should have been picked up in the consultation comments, and because the consultation closed in November. So if people feel that strongly about it, we look at that.
So
and as Kevin said, we respond to every stakeholder comment, and we change recommendations on the basis of comments. That's why we do it.
What we would do if it seems like there's a gap in facility or a service is to flag that up with colleagues in NHS England. As I said before, we can't do more than raise it with them. We can't, have no power. But we do routinely talk to them about what's coming through the guidelines and what's new so that they know.
I'm going to draw this session to a close, but before I do, I'm going to ask my colleagues if there's any further question they'd like to ask, and then also to you, whether there's anything you'd like to ask us. So, Sonia, thank you.
I just have one question. It's actually historic. It's to do with mesh. When CERNIP reclassified mesh, it went from category C, which was safety and efficacy not proven, 2 jumps up to category A, which was safety and efficacy proven. Would jumping sort of 2 categories be normal for guidelines or guidance?
So, the answer to that, it doesn't sound...
Well, I can only speak with the interventional procedures program.
I do realise this is historic. I'm not asking for...
That would be a very unusual thing to happen. So if you take our 4 levels of recommendation, to move 2 levels would be unusual.
Yeah. And the other thing is that we have heard that CERNIP reconsidered its classification at the request of manufacturers. What's the role with manufacturers in terms of requesting changes to NICE guidelines?
So no one can request, if you like, a change to NICE guidance. Anybody can ask us to look at any of our guidance again, or indeed newly notify procedures to us to look at for the first time. And that includes manufacturers, it includes patients, it includes clinicians. Historically, most of our notifications or requests for updates come from clinicians, actually. But manufacturers do that as well. The update we then have a process to consider whether update, and it has to be based on new available evidence. So they can't just ask us to update it because they would like us to update it. They have to, and to be fair to many manufacturers, sometimes they will produce new published evidence which they would like us to consider, and that's often viewed as a legitimate reason for doing it.
Okay. No. So over to you. Anything you'd like to ask of us?
Do you have any questions? I think thank you for the opportunity to come and talk to you, and if there is anything that can be done to encourage a stronger mandate for the system to respond to NICE guidance, especially in relation to safety, that would be great. And anything to facilitate a fit-for-purpose mechanism for data collection that we can use as well would be fabulous.
Well, thank you so much, and for spending all this time with us, over an hour and a half, so thank you very much indeed.